so others can view. All right, let's get started. So I have the pleasure of introducing Dr. Angulo, who is a core faculty member of AltaMed's Family Medicine Residency Program. Dr. Marco Angulo brings in an invaluable combination of experience, perspective, thanks to his background of working with and training residents in a federally qualified health center setting. He's committed to supporting and growing the program and helping create a strong workforce that is well prepared to serve the medically vulnerable areas of Southern California. His passion is personal, since Dr. Angulo was raised there. Even before he became a physician, Dr. Angulo knew his life's work was to serve these communities. He graduated from University of California, Berkeley with a degree in Chicano studies. He entered medical school at the University of California, Irvine, and participated in the program in medical education for Latino community, or PRIME-LC, which was created to develop physician leaders to address health disparities in the US and beyond. Dr. Angulo stayed on as faculty member at the UCI Family Medicine Department, where he served as Director of Diversity and Inclusion for the medical school and as the Director of the PRIME-LC residency program. Prior to joining AltaMed in 2014, he also served as Chief Medical Officer of an FQHC in Santa Ana. In 2016, UCI awarded him the prestigious ARISE Award for creating an innovative health navigation program focused on the needs of FQHCs. As well as when he was a resident, he was awarded the AAFP Bristol-Myers Squibb Award for Excellence for Graduate Medical Education. He's also an inductee into the Gold Humanism Honor Society, which at this point is a given as I'm reading his bio. Throughout his career, Dr. Angulo has challenged the next generation of physician leaders to chip away at health disparities and develop solutions that lower barriers to patient care. He's also created the Health Scholars Program, one of the largest volunteer and clinical experience programs in Orange County, dedicated to closing gaps in care and helping patients more effectively navigate through our health system. He's an avid baseball fan, go Dodgers, and his goal is to watch a baseball game in every Major League Baseball stadium. He's made it to 11 with 19 more to go. I have currently only made it to 2. We also have Gloria Montiel with us, who's a PhD and is a DACA recipient and a Southern California-based health equity leader. Born in Guerrero, Mexico, she immigrated to the United States at the age of 8. In 2005, she became the first student from Santa Ana High School to be admitted to Harvard, where she earned her bachelor's degree in English and American literature and language. She later became the first undocumented student to obtain a master's of education from Harvard Graduate School of Education, and the first undocumented student to obtain a PhD from the Claremont College University. Her dissertation focused on the identity and college experience of Latinx undocumented students attending highly selective private colleges. In her professional capacity, she has led the acquisition of more than 18 million in grant funds for community-led programs in public health. She currently serves as a research scientist at AltaMed Institute for Health Equity, where she leads the design of the organization's strategy to advance health equity through policy systems and environmental change initiatives, and as the consulting director of strategy and sustainability of the Latino Health Axis. Dr. Montiel also teaches graduate level courses at the Claremont Graduate University and the Allies of Dreamers certification program. Her academic work has been published in Harvard Journal of Hispanic Policy, a handbook on promoting social justice in education, and in various other edited books as well. Welcome. Thank you for coming.
Thank you. Of course. We hope that this will be a very lively discussion. Please interrupt at any time, ask questions. I am joining you all from my car because life happens, but definitely hope that this will be a fruitful discussion. Dr. Angulo, anything you want to say before starting?
That just that we're honored to be here and just seeing a couple of familiar faces here. So it's awesome to see that. And it's anytime that Gloria or Dr. Montiel is speaking somewhere, I love to be there just to be next to her because she has such insightful things to say. So proud to be a colleague with her over at AltaMed.
Thank you so much, Dr. Angulo. So our presentation today, we want to talk to you a little bit about what a culturally concordant care is and why it's important, especially here in Southern California. And one of the way that we like to frame this really is how do we mobilize healthcare for immigrant communities? So it's not just about providing a service, but really about mobilizing people who will be then be able to not only take care of their own health, but also promote health for others as well. So this is an overview of our agenda. We hope to provide an overview of immigrants in the United States, healthcare access among immigrants, and health disparities that affect immigrants, and then the impact of social determinants of health. We'll then get to a discussion with Dr. Angulo about some of the things that he's seen out in the front lines, and then after that, conclude with really what it means to provide culturally concordant care in a way that, as I mentioned, mobilizes communities. So in the United States, there have been traditionally sort of immigrant destinations. As we know, California has been one of them, and that's mostly because actually California and a large part of the Southwest used to belong to Mexico as well. So some of those kinds of travel patterns between our friends at the southern border into the United States have continued throughout this time as well. New York City has also been a huge immigrant destination. If we think about kind of the immigration waves in the 1800s, the Statue of Liberty is clearly there for a reason, and it used to be one of the main ports of entry as well. And as well as here, Miami and Florida, and then Texas as well. But if you can see some of these little dots too, it shows that there are new immigrant destinations throughout the entire country. And there's more kind of happening also up here in Idaho and in other places that have traditionally not been immigrant destinations. So that kind of comes with additional challenges for communities and healthcare organizations to be able to actually provide adequate care for our communities as well. The United States has over 44 million immigrants, more immigrants than any other countries in the world. It should also be noted that despite the rhetoric that we hear in the news about a lot of the news about a large number of immigrants coming from other countries, et cetera, population trends tend to show that immigrants tend to remain in the United States for a very long time, which means that there are a lot fewer immigrants coming in than we had previously. Those folks who are coming in tend to be in the younger side. We've also seen a lot of a rise of unaccompanied minors coming into the United States. Whereas when we think about now the population of undocumented immigrants, they usually have been here for 15 years or longer. So really have found roots in our communities as well. In US and California, you can see the breakdown here. Majority of kind of where our immigrant communities, a lot of them are from Latinx origin. The row here all the way at the bottom in California is almost 50%, whereas in the rest of the United States, it's still about 44% as well. Here you further see the breakdown in California and then Orange County, where in Orange County, again, immigrants from Latinx origin are about 41% as well. So just to show you kind of the mapping of where immigrants are. There's also different levels or not different levels, but different kinds of immigrants. We have those who have legal permanent residency, and they are afforded a lot of the benefits of individuals who are able to be authorized to work, for example, have a social security number, have access to healthcare and other benefits as well, such as US citizens, except a lawful permanent residents cannot vote. We also have temporary visitors who have actually a visa or permission to enter the United States, but they're still considered non-immigrants. So because they are non-immigrants, they don't receive certain benefits. And in here, we also see certain levels of being undocumented as well. For example, a temporary protection status and DACA are programs that are temporarily protected, but in the case of DACA, it's renewable every 2 years. And because it's not law, and we've seen it a lot in the news, DACA has been threatened by the previous administration, and certainly even right now, states could take further action if they wanted to sue the federal government, et cetera. So these are temporary programs, as well as a refugee status is a different type of non-immigrant visa, right? But refugees obviously come with additional protections as well that TPS and DACA holders do not have. And then undocumented immigrants, also referred to as unauthorized immigrants. What we never refer to undocumented immigrants as, however, is illegal immigrants. That term should not be part of our vocabulary because it dehumanizes communities as well. But undocumented immigrants are immigrants who either came into the country with a particular non-immigrant visa that then expired, or individuals that came, as in my case, without any authorization to enter the United States. And undocumented immigrants do not have access to any of the public benefits by law that other folks may have access to as well. And here's kind of the breakdown. So again, just kind of to note that less than 25% of all immigrants are undocumented immigrants, whereas everyone else kind of has a varying degree of rights in within this country. But that also means that as we're thinking about our immigrant population and where we are, the disparities will lie, it will be with those that have the least access to certain public benefits, et cetera. So healthcare access among the immigrant population. So in 2018, there was a Kaiser report that showed that 23% of lawfully present immigrants and 45% of undocumented immigrants were uninsured. And that's compared to only 9% of US citizens who were non-insured. And among citizen children, those who with at least one non-citizen parent are more likely to be uninsured compared to those with citizen parents. So this is where we start to see kind of the disparities, at least in healthcare access, where immigration status really affects one's ability to access healthcare. And as we'll see a little bit later in the presentation, but as I hope that it's been clear by now, in terms of COVID, there are certain public health crises where access to healthcare is everything. And if we don't protect the most vulnerable among our communities, it poses a threat to all of the welfare of not only them, but a lot of other people too. And the other people's inability to take care of themselves or willingness to follow public health lines will first and foremost impact those individuals with the least access as well. Now from access, we move to utilization, because we know that not just because somebody has access means that they will be able to fully utilize healthcare benefits. Research shows that immigrants with fewer years in the United States usually have lower rates of both physician and dental visits. And immigrants face additional challenges when providers lack culturally competent services designed to address varying levels of immigrant acculturation. For example, a lot of communities, especially in medically underserved areas, we may not have individuals from the same culture of the community providing care, which means that physicians or providers are making a lot of assumptions as to why certain healthcare issues may arise without really taking into consideration that immigrant experience as well. However, there's also, again, in spirit of demystifying sort of this rhetoric that constantly says that immigrants are a drain on our resources, et cetera. In national costs, immigrants account for less healthcare expenditures in proportion to their population compared to native-born individuals. So again, there's this idea of right, there's this need to present these statistics, but at the same time, we know we need to do better in reaching reaching our immigrant populations as well. And here it provides the expenditures for LA as well. And now moving on to healthcare disparities, there is what is called the healthy immigrant effect, which means or refers to the fact that when recent immigrants come to the United States, they tend to be in better health than sort of their native born than the immigrants that tend to stay here the longest. So that says something about sort of the conditions in which immigrants come to in the United States that makes their health deteriorate over time. And then, again, this national vital statistics system also showed that immigrants have better infant, child, and adult health and lower disability and mortality rates than US born, with immigrant health patterns varying across racial and ethnic groups. Immigrant children and adults, however, fare substantially worse than US born in health insurance coverage and access to preventive health. But within that, one of the things, as I mentioned, that as generations of immigrants stay for longer, their health outcomes tend to be worse. And if we think again in terms of where, especially those who are of lower socioeconomic means, where those individuals tend to have access to living opportunities, education opportunities, and career opportunities, it's not likely going to be in places that are conducive to health, because there have been structural policies that combine with sort of the racism and nativism that's present in the United States legal system and in the structures that disseminate healthcare, makes them kind of have these healthcare disparities over time as well. And of course, again, going back to undocumented immigrants, that population in general may have, because again, they have less access, also additional health concerns that go unaddressed. And a little bit more data in terms of specific health disparities. There was a national evaluation of the conditions of immigrant populations, and nearly a third of those individuals from Mexico, the Caribbean, and Central America had some of these conditions: hypertension, obesity, diabetes, compared to kind of the same population of the general US population. So again, it's not necessarily that individuals from these countries inherently have these predispositions, although some of them genetics play a factor. But immigrants in these from these origins tend to have kind of limited resources, and as I mentioned, and we'll talk a little bit of social determinants of health, tend to live in places where social determinants of health really impact their livelihood and their ability to access care. And depending on their mode of entering the United States, if we're thinking again about the children crossing the borders, if we're thinking about refugees, or if we're thinking of other individuals that kind of have to travel for long periods of time to be able to reach the United States, there may be a risk of additional trauma related to the poverty, the trauma of migrating, and poor social support, which then also leads to a lot of mental health conditions such as PTSD, depression, and anxiety. And in a lot of immigrant communities, because in general in the United States, there are fewer resources for mental health, these communities will continue to have these disparities because they go unaddressed and because there aren't enough providers that can provide services in the culture and in the language that they need. As we start to think about how these kind of conditions have impacted in COVID, this is old data. This is data from 2020, so from last year. But as we start to see, see the patterns of Latinos and other kind of ethnic minorities, and I don't necessarily like using that term, but Black and Brown communities, I should mention, I start to see the disparities, and not only in COVID infections, but also in deaths as well. And we see, especially as we see that although their share of California population, which is the blue graph here, the share of COVID deaths is way high, when that's where the disparity actually comes from, that we shouldn't see this population being this affected because they're not that much of that population. And so that's sort of how we describe a health disparity, in which a population is disproportionately affected by a certain condition that could be prevented. There's been a lot of things that could have been done to be able to prevent that impact. And we see kind of the same patterns here on to the right as well with other ethnicities, as specifically, or race, specifically with our Black population and then Latino population as well. And now, in speaking about social determinants of health, there have been studies that compared to the US born population, immigrants and their US born children typically have lower rates of health insurance, use less healthcare, and receive lower quality of care. If we see the social determinants of health framework, we see that these are the conditions that really impact an ability, where people live, play, work, and go to school as well. And so in this, we have access to education, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. If we again reference to the pandemic, one of the first populations that was impacted by financially during COVID was the Latino population. And if we think about also, they were the least likely to be able to have time off from work or to be able to work from home. And so that really impacts their ability not only to get care, but also exposes them to greater risk. And that same thing could be said about all other kind of preventable diseases as well that impact communities of color as well. That it's the lack of infrastructure to address these social determinants of health that really exacerbates some of these conditions and health disparities, and ultimately also deaths of our community. Again, in Orange County, we can see that some of these cities where the majority of the population is Latino also has large rates of diabetes. And then we see before that childhood obesity as well, and other things that could be prevented. But usually healthcare systems say, well, you know, if your child is overweight, they just need to walk more, they need to eat better, right? But how can you tell a family that when there are no parks that are safe in their community, and also they don't have enough money to buy healthy food, when you go to McDonald's and a salad costs $6 and a cheeseburger costs $2? And so these are the issues when we talk about social determinants of health that I encourage everyone to think about. Not only how do we create interventions that affect our patients and our community members on an individual level, but really how do we mobilize healthcare systems to do more to address these issues that are systemic in nature through policy systems and environmental changes as well. In Orange County, again, Stanton and Santa Ana have the highest percentage of individuals with household incomes that are well below the 50th percentile for all demographic variables. So I think, again, this idea of limited income and how that translates into access and their ability to sustain a healthier life. And as I was mentioning as well, Santa Ana, Garden Grove, Stanton, and Westminster have 1 acre of parkland per 1,000 residents, versus Laguna Beach, for example, that has 69 acres per 1,000 residents. So people's ability to lead healthier lives just becomes the norm versus folks in these other cities that really may not have that access. And there's also a lack of social networks that impact our community's ability to thrive. For example, in South Orange County, we tend to see that as a community that's really, really wealthy. But however, there are pockets of immigrant communities or Latinx communities that don't have access to additional resources, and infrastructure for social services for that population is very limited because everything is kind of hidden by the wealth that exists in South County. The bus systems, for example, don't run as frequently in South County. So as we're thinking about our communities that don't have access to a car, it's difficult for them to get to appointments, not only in their healthcare, but other services as well. And the proximity of our communities to the border also creates additional risk and additional fear of really seeking out services as well. And again, it's virtually impossible for undocumented immigrants to have access to healthcare as well. Now, this data is from about a couple weeks ago, from April 5th. But again, all these things, the fact that housing is super expensive here in Orange County, the fact that, for example, in my case, growing up, there were 21 of us living in a household. And so if we're thinking about, and that's still the reality for people today. And so we're thinking about a disease like COVID-19 that kind of thrives in that environment where people are in close proximity. We see how and why COVID spread so fast among our communities as well. We start to see some of these same disparities here, where especially the Latinx folks are there 35% of the population, but 46.63% of the actual cases, and then 35% of the population, but about 37.69% of deaths. And the same thing could be said about hospitalizations, and our Latinx communities are also less likely to recover faster or take a longer time to recover, if at all, also. So this is how sort of the trajectory of the social determinants of health turn into actual health disparities that obviously in a pandemic are just super exacerbated and urgent for us to address. And again, and just recently, the administration announced that it was going to drop the public charge. Public charge was something that has existed since the 1800s. When the Irish immigrants were actually coming into America, a lot of them were actually very poor, and so the immigration sort of system would reject individuals who were either ill or who would have very little means, because of this idea, again, that there would be a charge on our public health system, on our resources, etc. The Trump administration readopted some of the same language from way back when, and kind of tried to strengthen the public rule, which still exists right now. There are certain benefits that if an immigrant takes advantage of these, for example, healthcare or housing benefits within a certain time of being a legal permanent resident, they could be denied an application for citizenship. And so the Trump administration wanted to increase the number of benefits that would be eligible to be a public charge. So with the intention, again, of rejecting more citizenship applications from communities of color who were immigrants as well. So the Biden administration actually said that it would no longer pursue this, which was great news for our community. At the same time, the media did a lot to communicate the threat of public charge, but it hasn't done enough to say that it's no longer going to be an issue, which means that our communities may still refrain from seeking essential services during COVID because of fear that it's going to impact their immigration status later as well. So and I'll provide these slides a little bit more about the public charge rule here. But so with all that, now that's kind of laying the background, right, of just the context of immigration and what are the issues that we see in our communities. But we want to really hear from Dr. Angulo and to hear sort of his perspective of working in the front lines. And so I'll facilitate a few questions for Dr. Angulo. And the first is, how was the community AltaMed serves impacted by the COVID-19 pandemic?
Yeah, Dr. Montiel, you always charge me up with your talk. I feel we need to do more. I'm sure everybody here, somewhere along the way, is making their way through some kind of health career, some kind of medical career, right? So this is, Dr. Montiel's talk is so important because there's certain things that we think about, but it's kind of an afterthought, right? And I would say, I'm a family medicine doctor, I would say 80% of my medicine, 80% is social determinants of health. I can give away insulin all you want. I can give away blood pressure medications. But then if my patient cannot get to see me, if my patient can't get that medication, can't pay for this, then forget it. Then it doesn't happen, right? So it's things to think about, and we have to actually start thinking outside the box. a little bit of how we're serving our communities, and changing the way we give medicine. But as far as COVID, I'll tell you, I'm going to go back to in the March. If you guys could all recall where you were last March, the 16th, 17th, we got a shutdown, and the entire California, the whole nation goes on shutdown. And now we know a little bit more, so it's retrospective, hindsight 2020. But we're dealing with something that we have no idea what it is, right? People have been dying from it. You can catch it just by, seeing someone, or that's what the thought was, like, it's just so contagious. And our whole entire nation shuts down. California shuts down. And we start seeing that people start getting tested and want to get tested and start getting sick. People are inundating themselves into the ER, into the ICU back in March, right? The best way, Dr. Fauci was saying, is we have to make sure to test everybody to see where everybody is, to start quarantining people, start making sure that we're staying away from each other and isolating people that are affected, right? I got called in, and I'll tell you the truth. And I always remember this date. I was, mortified, thinking, okay, I'm going to go in and start testing patients that possibly have COVID, upper respiratory symptoms, with all the symptoms, right? So you think about your family. You think about, am I going to bring this home to my wife? Am I going to make my mom sick? So all these things are coming to mind. But then you also think about, like, if I don't do this, then who's going to do this? If I don't get out there to start just making sure that I do the best I can, but make sure that to give back to my community in that way, then what was my medical career for? Like, it felt like this was, for us, the Super Bowl, that we had to get out there, and by any means necessary, we had to do it, right? So one thing that I'm really proud about is that I worked for a fairly qualified health center, AltaMed, and believe me, I'm not what you call recruiting for AltaMed, but I was so proud to work here because we saw places come up like Dodger Stadium. We saw places come up like in Irvine, and they were places that were not hitting the community that we lived in or that we worked in. And for us, we said, you know what, even if we're going to take a loss, we're going to go ahead and set up 9 sites in all the AltaMed areas. So we ended up doing that, and we ended up testing a lot of patients. One thing that did come up is, and was really frustrating, is that patients would come in, we would swab them, and they'd be like, wow, you're positive for COVID. Mr. Sanchez, you're positive for COVID. I need you to go home and I need you to isolate. And like Gloria mentioned earlier, the patient would be like, how am I gonna isolate if we live in a 1-bedroom, or we live in a multi-family? Right? So those are some of the things that we were really frustrated with ourselves. How do we make this system better for our patients, right? The other one was, well, Mr. Perez, I'll have 2 weeks off for you from work, take it off, quarantine, so you don't have to do, so you're safe and others are safe. And Mr. Perez would be like, well, how am I going to do that? How am I going to pay the rent? So those are the things for me that I remember that was absolutely drew me back, because it was, you think about them, but you don't think about the impact patient after patient after patient, that you have to think, like, what are we going to do for these amazing patients that we're looking after, that have given us their trust. And we ended up actually creating a Health Navigator outreach program to make sure that we have all the aspects of the community to make sure that patients were open to whatever it was, whether it was hotel housing or whatnot. So that program actually ended up doing really, really well. But at the same time, our clinics shut down, patients were coming in anymore, and diabetes wasn't solved yet, right? It was still out there. My patients still had diabetes. My patients still had heart disease. So then what are we going to do about that, right? So we ended up, all of us, calling our patients, making sure they're touch base, making sure that they were doing okay. So these are the things that for us was all brand new. And we ended up doing a whole telehealth visit on a dime. Everything turned telehealth because we can actually call our patients. And I got to hand it to the health navigators. They did an amazing job in making sure that our patients were taken care of, and they directed them back to us. They were the extension of myself. But during that middle of the pandemic, when people started coming back, you really started seeing the effect, because you started seeing the patients that you've always seen and coming in for their regular treatment is, oh yeah, my father passed away of COVID. Or, you know, maybe a patient that I hadn't seen, I called and they're like, oh yeah, they just recently passed away of COVID, which is something, you know, it hits home. It hits home because those are the people that you love to work with all your life. You wanted to make sure that they were taken care of. One definite hope that came through, but was probably one of the most difficult things in my entire life, was when we did get the COVID vaccine back in December, and it was by December 15th in that area. We actually, and this is also something I'm really proud of, the organization I work for, is that Dodger Stadium, Disneyland, we're already starting to give the vaccine to everybody around that can go. And our organization said, you know what, we love that they're doing that, but we know where our community is. And we wanted to make sure that we were taking care of our community. So we actually ended up opening up every single clinic that we have in Southgate, South LA, Commerce, Boyle Heights, East LA, Santa Ana, and saying we have to give that vaccine to everybody that we know, not only for our patients, but for the community members. And this is, I mean, I'm going to give props to Dr. Montiel, because she helped us so much to outreach to that community, to our community, and make sure that people in that community, Northgate showed up to our front door. Latino Health Access was there to make sure that we were getting vaccinated. And we couldn't have done it without community partners. And for us, it was so important to work with those community partners. But you know, I'm going to share this one story, and it always sticks with me of how much information is out there and how much we need to continue to talk about and educate. It's always a teaching moment. I had a friend of mine from the ICU call me, and we would talk often because a wonderful friend. But she said, hey, I have a question. She goes, my entire ICU is filled with Latinx people, Latino people, and they're just, you know, it seems like every bed is filled. And then she's like, do you know why they're getting affected so much? Is it because you know, they're not showering? Is it because they're, oh my God. I was like, okay, first of all, I'm going to be patient, right? But this is a physician that's telling me this. So for me, it was an opportunity to say, hey, look, let me tell you what I see on my end. Let me tell you how things are going on my end. And I want to make sure that you know what our patients are going through and how we're doing that aspect. So these are some of the things that we have to see the bigger picture and how that affects it. COVID-19 actually uncovered the disparities even more than we even thought were going to be uncovered, you know. And for us to make sure that we reached out to our communities, we reached out for the vaccine. So right now, AltaMed has given over 40,000 vaccines to our patients, and it's the true meaning of health equity. And I know that you know the definition of equality versus equity, but I always like to use the example of, you know, equality is that everybody is getting a 10-speed bike. You get a 10-speed bike, you get a 10-speed bike, everybody's happy about that. And then everybody should be okay. But equity is saying like, okay, well, maybe that bike does not fit for someone that is that uses a wheelchair, or someone that's 3-year-old that can only drive a tricycle. You know, so you have to make that fit for that. And I think for us, for people that were born in this community, or people that really cherish the voice of the community, it's really important for us to see and to reach back to make sure that we are fitting that puzzle and making sure that everybody is being seen regardless of race, ethnicity, gender, and everything. So next slide.
Thank you, Dr. Angulo. And in that, can you speak a little bit about how, like, for example, in that experience you shared with a colleague in a different health system, how do you then provide, how can providers care for patients in culturally sensitive ways? How do we really see our communities as assets in the clinic and provide the care that they deserve based on sort of people's humanity?
Yeah, no, that's a thank you, Gloria. That's a great question, and for me and myself, this is something that I grew up in this community, and I've felt that it's every patient that I go in and I see reminds me of my family member, reminds me of my grandparents, my mom, my dad. So before I knock on the door, and I think that and I know Reese is going to go off to family medicine residency. But the joy is going in retrospect and feeling, okay, look, I have the ability to actually make this visit home, make this visit as comfortable as possible for that person on the other side of the door. So when I do go in, I think about all those things. But Gloria, also, it's helped me actually, not just for my Latinx community, it's helped me see this for other ethnicities, other races, and making sure that I'm absolutely absolutely just taking care of not only that person, but the entire culture and the entire community that person brings to that. So that's something that I've carried with me as well. It's in our DNA as well. So it's something that when you go off to medical school, it's something that you cherish the most. It's the funnest part of being a doctor.
Thank you.
Yeah.
And then if you can explain a little bit about how do we develop system-wide solutions to improve culturally concordant care? How do we develop physicians, providers from our communities to be able to then come back to our communities?
We need to train them. So yeah, this is the training for medical education. I think that in medical school, as a physician, I think maybe there's a primalcy program, which is fantastic, right? But maybe there was a semester of this peppered in here and there. But of course, you get all the hardcore medical knowledge. But sometimes in the medical profession, this is seen as like the extra stuff. The AAMC, the Association of American Medical Colleges, right now states that there is going to be a shortage of 54,000 to 130,000 physicians by 2033. And for us, and for myself and AltaMed, my title is Medical Director for Medical Education. My goal is to train that next generation of providers, of physicians, to serve the medically underserved community, to actually know and experience in every visit everything that Gloria talked about. And that's what we do in our residency for family medicine that we have in AltaMed right now. But we're also doing a nurse practitioning fellowship because we think it's important that not only do they get great medicine, but they get great cultural care as well, and a great concordant care. But it doesn't stop there. We actually went even beyond to undergraduate, to where we are creating a pipeline that's coming through. We have the HCOP program that we've developed, a health career opportunity program. We have the primary care leadership program for the medical students that are coming through. And we have rotations specifically for the medically underserved community. It's something for us that's incredibly important, and for us to pass that knowledge on to others, that with the things that we have learned ourselves is the most important. And really focusing on that.
Thank you. I do want to do a time check. We're at 6:47. So if you can briefly just explain one of the ways that we can provide culturally concordant care, especially for immigrant communities, are federally qualified health centers. So if you could please give us a little bit of an overview of what community health centers are and what their function is in our community.
This is the greatest thing since sliced bread. Let me tell you, when I was going through medical school, I was like, well, I'm going to be a doc that works at a free clinic, and that's the way we're going to do it. And we're going to outreach, and we're going to be, making sure that we're always having funding coming through for grants and with whatever, whatnot. I don't know how we're going to sustain it, but we're gonna keep it going. Federally Qualified Health Center is absolutely the way to do it. So I'm going to give you an example of how it works. Actually, I'll let you know. So then we have over 16 Federally Qualified Health Centers in Orange County, which you see the pictures on the slide. We offer care to everybody and anybody, regardless of ability to pay or not, regardless of documentation or not. That's something for us that we're very proud of. We have a full service of not only primary care, dental, optometry, we do behavioral health. It's a one-stop shop for everybody. These FQHCs were created in 1965, and they were created by a man that had a vision. His name was Jack Geiger. He recently passed away last year in December 2020 due to COVID-related reasons. But he set up a system in two places, in Mount Bayou, Mississippi, and in Boston. And the federal government actually was the one that gave the major funding for it. But he wanted a comprehensive care. What happened was he went, usually before 1965, you had mom and pop doctor shops all across the place. And he kind of went there and you're like, oh, I'll go to this doctor, I'll go to this doctor. He went to South Africa and he saw the whole entire system. And he said, wow, this is a one-stop shop place for the entire community to come to. And they kind of came to that one place and had it ready for that one community and tailored it around that one community. And sure enough, now we have hundreds of federally qualified health centers, not only in California, but all across the United States. So that's the only place I will work from now on. I've never worked anywhere else but an FQHC. Let's see. Oh, so then the next slide is actually talking about who the FQHC works. It's through the safety net. It provides healthcare to all, regardless of status. It provides health education, prevention programs, navigation, and other social services. Serves as a trusted messenger in immigration communities, reliable information, and advocate for immigrant communities and healthcare access, and works with the community partners to address all the social determinants of health. It's something for us that coming as a medical student or as an undergraduate, I didn't know about. And now that I'm actually involved in that world, I'm realizing that a lot of people still don't know about what a federally qualified health center is and what it does. But little by little, we're starting to get the word out in our community of what it does. So regardless of pay, regardless of if a patient comes in and they cannot afford to come and pay, we can actually waive the cost and be okay with it. Yeah. So what we do at AltaMed, we have 55 locations. We have 26 medical sites and 11 dental sites. And we have about 300,000 total members, and then 73,000 in Orange County. And it's about 1 million visits now. And about a million of those visits, right now, 60% are telehealth visits. And it's actually the largest health care FQHC in Southern California. I would argue it is the largest healthcare FQHC in California. So, and our mission, we all memorize it, to eliminate disparities in healthcare access and outcomes by providing superior quality health and human services through an integrated world-class delivery system for the Latino, multi-ethnic, and underserved communities in Southern California. When I first came to AltaMed in the corporate office, and I believe John's on this call, he's been there at corporate, it's actually etched on the floor. So it's a place where it really believes in the mission. And I hopefully with Gloria, I plan to retire from this place. It's been home to me. So
Yes, absolutely. Thank you so much, Dr. Angulo. As I mentioned earlier, that part of this really striving for culturally concordant care is really to change the culture of healthcare in a way that it mobilizes to not only address urgent health disparities through healthcare, but really to change the way we do healthcare in a way that it addresses some of these other inequities. One of the things that has been kind of the primary aspects of my job at AltaMed has been to develop what it looks like to have a civically engaged healthcare system, where it is really patients and communities who are leading our strategies, our programs, our grants, our research projects around social determinants of health, and really partnering with individuals from the community to really lead some of these drivers. Not only, for example, AltaMed has had now 3 cycles of nonpartisan voter engagement, but not only that, but really how do we get down to our neighborhood level, activate individuals to then mobilize for health. And I have one example featuring a couple of participants actually from this session. Within the kind of the politics realm, there's research that shows that if you tell someone you know to sign up to vote or to actually go to the poll and vote, they're more likely to do it than if some stranger from a different campaign or from just a regular campaign were to do so. And that's called relational organizing. Well, actually, one of the members here, Felipe, who's on this call, reached out after Dr. Angulo and I presented last year. And when COVID hit, he asked, how can we help? And so he and he's featured right here, and Destiny both reached out and said, you know, we know our community really well. There's this bike trail right across the street from where we live, and people go walking around this time. Could we actually do outreach at that time? And so through social media, actually, we got a few people together from different times. Now we've done 5, this is a little bit updated, but we've done 5 weekend events where we just set up posts. And because of the partnership between Latino Health Access and AltaMed, I've been actually having the ability to register people for vaccine appointments right then and there where we do the community outreach. And it's also shown us, for example, that just some of the same arguments that are used in terms of, oh, Latinx communities aren't politically involved, they're not engaged in their own healthcare. This experience has shown us that when given the opportunity, individuals will come to bat for like their health and the health of their community. We've done, we've talked about to about 200 individuals directly as they're passing by, distributed flyers, but that's resulted in over 450 individuals reaching out to us individually and or to Latino Health Access in order to book appointments directly with AltaMed Health Clinic. So this issue, for example, of vaccine hesitancy that we've seen that when we make it really accessible for individuals to just walk up to somebody who speaks your language, who can explain things to you in a way that you understand and not in super technical medical terms, individuals are more than ready to come and sign up for the vaccine as well. So how do we use this model to not only do this one-time thing when COVID is here, but how are we thinking about rebuilding through after COVID with equity, of really taking this neighborhood approach of convening individuals from the community to be able to lead the strategies that are going to serve as the basis for health and economic recovery long-term. And so this is the way that we really, as we work toward equity, we really need to center the voices and the experiences of individuals who are most impacted by health disparities and inequities to help us lead strategies to address them. So thank you so much, everybody, for having us here. And we'd love to engage in conversation with you all and answer any additional questions.
Not seeing any questions in the chat so far.
We just saw a picture of 2 people who asked a question and they ended up getting 450 people vaccinated. So I think you should ask a question if you're on. These are 2. Yeah, it's just a wonderful way to to augment the experience of the other people in the audience, and just to learn something cool. And there's no dumb questions with these two. So please.
Absolutely. You know what, John, though, I wanted to bring something up because I was even thinking, like, just thinking about the health equity part. I don't know, Gloria, if you were on the call with the Blue Shield people. Remember when they were trying to, it's called My Turn, right? When you go on the website, have you heard of that? And you go on there, My Turn, you kind of put your information on. It's pretty lengthy, but all of us from the FQHC world were on this one call. The CPCA was on this one call. And it was so interesting to see the dynamics because Blue Shield was like, well, we got the website going, so there should be all equality. Everybody should get it. This is health equity at its best. So everybody has access to it. Here's the website. And we were like going crazy, like, well, how, for me, I was like thinking, how is my Senora Sanchez gonna actually, first of all, does she have internet access? Second of all, does she know how to use a computer? Third, so I kept on going down. And I think that they, at the end of the meeting, they got it. They're like, oh, but if we weren't at the table, if CPCA was not at the table sitting there kind of directing this and saying, okay, this is wrong, you guys are way off, then it would have just gone off and just said, hey, look, and then once again, like Gloria was saying, and look at this population that doesn't want to get vaccinated. It's all this hesitancy, vaccine hesitancy, which I know Dr. Montiel and I just cringe at this because give us the freaking vaccine, right? That's the, so those are the things that drove us a little crazy during this whole process, to make sure that people were asking for it. People in our communities were asking for it. And yet the vaccines were trickling in and weren't coming to those communities. So it was great to be placed at the table. And I think Dr. Montiel has done a great job in mobilizing the community and getting them into the line, so.
Yeah, and then the other thing I'll add too is that as you transition into medical school and then actually become providers, that power of the white coat gives you so much, gives you a unique platform of really advocating for your community. So you're not just providing healthcare within the clinic, but you're also showing up in a way that, to meetings that are convened with your local healthcare agency or even within your health system, and really putting the voice of our communities front and center from your provider perspective. And I think that's been invaluable in some of the different strategy meetings that we've been sitting around together with Dr. Bilimek as well, as many people that can represent and uplift the voices of the community, the better that we can force systems that are by design inequitable to act in ways that bring equity to the table as well. So that's as you develop sort of your career pathways, I encourage you to continue rooted in the community and also find ways to advocate that are not that leverage your platform as future providers in order to do so.
That's so right. I mean, I think it's such a special platform, and it comes with the white coat comes with the platform, and it also comes with a lot of competing demands. And I'm interested to hear y'all's perspective on, and just like even during medical training, and maybe Dr. Angulo can speak to this too, but just during residency, your schedule's so exhausting, and when you're kind of establishing your practice as a recent graduate from residency, it can be really exhausting. And then of course the challenges and opportunities for helping the community are so vast. Like, how do you keep your battery charged, as you're fighting sort of what could be an endless battle, while you're also being called upon to do many other things that aren't even part of the battle sometimes?
That's a great question, John. And for me, I think that hanging out with people like Doctora Montiel, definitely, right? You get that you, of course, but also, okay, so when you go to medical school, sure, you could still be an advocate, you could do all these things, but you're a student, you're learning medicine, right? You're getting your stuff down, right? And then when you go to residency, and Reese, I gotta tell you, your first year is gonna be all medicine, right? You're gonna be itching to do something, but it's like your third year, but on steroids, the third year of medicine. So then that's all you're gonna do. When you get to the next couple of years and you can start branching off, what I've realized is, oh my gosh, I have the ability to do anything I want in this profession. Like do I want to see patients? Yes or no. Do I want to do half? Do I want to work 40% patient care and 60% advocacy work? I can do that, right? So it just has given me this amazing freedom to do to build my own schedule, to build my own job, right? And I think we, as physicians, we have that ability because we are revenue generating ourselves. So if somebody says, you know what, you don't have a job anymore, I was like, okay, fine. I can go down the street and create my own revenue myself by opening up my own shop, right? So then that's what I mean by that. And just having that ability to realize, my goodness, there's a lot of the white coat. There's a lot of strength in this, and let me use it for that community. Let me use it. Let me help be that voice to make sure that we have what we need. You know, although with that being said, I'm in the clinic. You know, I'm like in all that. So I need my partners like Doctora Montiel. So because she's out in the community at all times, and she's got a beat on the community that nobody has. So for us to make sure that we are actually doing justice to our patients, she is an asset for me. She is someone that I turn to all the time and saying, what are we doing here? How can we better it? And let me, you know, so then, although you have that ability and power, you need all the allies that you can get. So that's definitely, it's Disneyland though. Right now I'm in Disneyland. I'm gonna retire from here. That's it, I'm done.
Yeah, and I did see the question on the chat too, and super important with the COVID example, how one would know whether or not we're successful in reaching those marginalized populations. And this is the power of data, right? Especially in an issue like COVID. But warning, that you really, even within data, you have to be careful and ask the right questions. At the beginning of COVID-19, the county of Orange was, for example, producing data that showed how many tests were being deployed in our community. But there were no specific data on how different zip codes were actually being impacted by COVID, the rates by which testing was deployed in these, and now vaccines. So this is actually part of the advocacy that Dr. Billimack and I have been involved with the larger Latino Health Equity Initiative in Orange County, of asking for the right data. Can we show data in the appropriate census tracts, or at the very least in the zip codes that we know have been historically disinvested and riddled with a lot of structural inequities. And so from that standpoint, then we can see, for example, have we been successful? What rate of vaccinations have been deployed in this zip code, for example? And that's data that we know because everyone who gets vaccinated gets entered into a system that goes up to the state, and the state reports back. And so that's data that we can actually know with an initiative such as COVID. The other piece, sort of not during COVID, but in general, it's this maintaining constant relationships of trust within communities. And this is the power of kind of having boots on the ground or partnering with organizations that do outreach, that constantly have streams of communication with community members, where community members can provide feedback, provide input on strategies, and community will tell you. If you give an opportunity for community to come share their experiences, they will be brutally honest as to whether or not some of your initiatives are working, what else needs to be done. But you have to, obviously in this realm of culturally concordant care, you have to either partner with the community CBOs, community-based organizations who are doing this work, or find ways within the health system to actually develop these community relationships also, so you can have that multi-directional communication with community as well.
Hey, Gloria, I wanted to share, I mean, one slide that I had that was just, I love this slide right here. So then you talk about data. Could you see that? Yeah, this is the social vulnerability index, and we have this built into our EPIC. Our EPIC is our electronic health record, and it tells us the overall vulnerability of a person, of a patient, of a population, and your socioeconomic status, household composition, disability, minority status and language, housing type, and transportation. 15 social things are considered for social determinants of health. As far as what you're seeing on the right, very high and high, AltaMed has vaccinated 80% of the population that we vaccinated is in the very high and high range of social determinants of health. So this is a way, like Gloria was saying, that we actually keep track of it and make sure that we're hitting the right population. And it tells us where to direct our mass vaccination sites. So the next one was like, okay, we need to hit Southgate. We need to do it big. We need to go 1,000 people in Southgate. So this is somewhere that we really take into account. We're using a lot of data for that. So that's all I wanted to share. Exciting stuff.
Yeah.
That's compared to all California. So 80% is compared to all California.
So we just had another question come in. They asked, in terms of vaccine distribution efforts, has the nation/state created guidelines or specifically sent vaccines to hard-hit areas, or has it mostly been up to individual communities?
Yeah, so a few weeks ago, the state actually of California identified 400 zip codes that have been some of the most hard-hit areas, and said that it would allocate additional vaccine resources to that to those specific zip codes again. And so that's one of the sort of clearest guidelines that we've seen. But a lot of it, sort of prior to that, a lot of it has been left up to individual counties to see how sort of deployment would. It had issued guidelines. For example, first tier was frontline workers. Then we had our older adults, et cetera. But within that, how counties kind of deployed their vaccines has varied a lot. And so that's been one of the pitfalls of this vaccine rollout, because there hasn't been kind of strict guidelines from the federal government or state government as to how to exactly do this in an equitable way. And it wasn't until further along that we got specific geographic areas of focus. But even within those areas of focus, I would say it's kind of limiting because that doesn't cover the surrounding areas that may be as equally affected as well. And so that's kind of the state of vaccine deployment at the moment.
And I just want to add, that was just recent though, Gloria. That was in the beginning of April. So we started in December, vaccinated our first crew December 31st. We worked through New Year's, and it was honestly, it was the rollout was not really thought through. But now things are getting to be a lot better. But it was pretty frustrating because you're just waiting to see what you got, and you didn't know if you were going to get Moderna, you were going to get Pfizer. And then the Johnson & Johnson wasn't even out, right? So then you're just kind of waiting for which one you're going to get.
And guidelines changed from one day to the next. I remember that because we had this partnership with Latino Health Equity Initiative, and I also work very closely with them and have been throughout the pandemic, we were on top of it to vaccinate educators when they became available. It was a Saturday night. We had just finished scheduling about 500 educators when the county said, you can no longer vaccinate educators because all of them will be taken care of by Orange County Department of Education. And so we stopped in our tracks. And at that point, AltaMed decided, right, that these individuals had been waiting. These individuals work in our hardest hit communities, and for protection of our communities, we needed to fulfill those appointments and perhaps reevaluate afterwards, but we were going to keep those appointments. So it's been a whirlwind, to say the least.
All the gray hairs right here on this side right here and on this side, that's all because of the beginning of the, but I'll tell you the truth. This is honestly one of the most gratifying things I have ever done in my entire life. I mean, when you see 500 people come through your vaccination center, you're like, this is family medicine for me at its best, you know? It's a great question.
The only downside I ever see of speaking with Dr. Montiel and Dr. Angulo is that you just see how far along the path they are, and all they've gained, and just the experience and the access and the connections. And sometimes it can just feel like, well, how can I mean, I'm really not blowing smoke when I say, like, how could we ever even approximate a path like theirs? And I guess I'd be interested to know, just to hear, y'all's perspective on, some of these people that are still in their training, maybe maybe didn't grow up in a community that was affected by some of these inequities. What are some early, examples or advice about how do you start taking some of those early steps towards leadership in a health equity initiatives? Where do you start?
Well, I'll start. It's a great question, John. I think that even when I cringe a little bit when Reese was reading my bio, because nobody, the only people that are around to see all that, even all the mistakes that you've made, are the mentors, right? But all the stuff gets left on the cutting room floor, right? All the mistakes, all the heartaches, all the tears, all the blood, all the sweat, all the things that you've gone through, all the mistakes that you've made. You're like, oh my, why did I do that? And things fall apart and you have to build them back up again, and it's truly just finding that purpose, right? It's finding that purpose in life and saying, you know what, I need to do this. I need to completely, this is my life, right? Once you find that purpose, forget it. There's nothing that's going to stop you. And you're going to continue, whether you fall flat on your face, which I've done thousands of times, right? And you get up and you just keep going, but you have that one mission and vision and drive that keeps you going. The job's not done yet. And that's why I think between what I was born 1970, who knows when I'm gonna die, right? But between that little hyphen between that time and that time, that you leave it on the floor and you're like, wow, this is what I'm here for. So.
Yeah. And in terms of kind of practical things, again, this work on inequity or toward advancing health equity really has to center the communities that have been most impacted. And so if we're not from those communities, or we're entering a new community, number one, just listen and begin kind of establishing those personal relationships. And the way you do this is by engaging with those who are already doing this work in these communities. Community-based organizations, even if they're not formal groups, there's a lot of organizing groups that just do the work without necessarily having a formal structure. Show up to their events, follow them on social media, amplify sort of their mission, their goals, and whatever strategies that they're working on, and then engage with them in terms of any volunteer opportunities that are possible. Another way too is perhaps communities don't have those resources to elevate some of their work into best practices. So can you, as folks who are seated, going through a university education, can you partner with them to write an op-ed, for example, and look for ways to mobilize your talents, your privileges, to again uplift these communities as well?
Yeah, that's outstanding advice.
And then I think Dr. Cervantes, maybe you already answered it, I think you might have already answered it, had a question.
Well, a little bit, but yeah, I think the one of the key things in Brett's question is so what are these critical steps in order to advocate for the essential resources our communities need, but when others might not see the benefit? I think that's a really key part of this. Is some people don't recognize the scope of the problem, and I think you talked about data. What else do you recommend to sort of help people understand the potential benefits of equity-related work?
Yeah, and then the other piece too is really bringing some of those stories to life, right? Like one of the things, and changing the way that we also refer to our communities as well, because it all starts with language. For example, I've been a grant writer for most of my professional life until very recently. And usually as you're writing a grant application, they ask you for your target population, right? But for us, in an equity sense, we're not targeting any population, we're partnering with these communities. So really focusing on the way that we approach our language and the way we refer to communities is also another way to kind of address some of these issues that perhaps it's just a reframing of the language that we use that will hit someone to really understand why it is that we want to invest. And then the other piece too is that we just have to do it no matter what, right? And some of these things, obviously, as you're growing your professional career, you'll want to also learn how to navigate the politics of being in whatever setting that you are. Because clearly we do want job security for you all, and we do want to make sure that you get to the position where you can advocate no hold bars, right? But at the beginning, just definitely find allies within your health system that perhaps have a little bit more tenure there and that see your point of view, and then collectively design a strategy to advance some of these health equity strategies within your organization. Because, and then that the other piece I'll say is that this work doesn't happen alone. It's not just one person advocating, because that's when we hear about burnout. That's when we hear about, failed missions, people change careers, et cetera. And so that's why this idea of allyship and really working with people who understand within your mission, but also within your system or wherever you're working, but also external to it, is one of the best ways that to get things done. And I'll say, especially for COVID, the COVID work in Orange County, no one organization could have advocated alone for some of these resources, especially those community-based organizations that sort of depend on public funds to carry out their work. But that's where we have, for example, the role of UCI stepping in as our partner, who doesn't necessarily depend right now on like their vaccine allocation from the county, et cetera. And they can be our leaders in being a little bit more vocal about sort of some of these equity frameworks. So just some thoughts.
I just wanted to add that I've learned that it's not. I always used to say it's just the right thing to do, and you just can't say it's the right thing to do, right? You have to come back with data, and you have to give the return on investment. This is something for me that I've discovered along the way, saying, okay, like, so that Brett's question is even how do we change our culture, not only maybe at AltaMed or at another organization. You always show that benefit. Like, here's the data, and here's how that can benefit this organization or something. And that's, for me, that's helped our initiative. But I used to be well, that's just the right thing to do, which is always the right thing to do, right? But it's you need that.
Yeah, I think it's right. I mean, it really is that combination of the narrative and the data. I mean, it has to be relatable. And, earlier today, we had a speaker from the regional center of Orange County, and he talked about, he met with a state senator recently about the funding related to things. And he basically found out that person had a relative who was affected by disability, kind of, really contextualized the story of the regional center in the context of folks like that family member. And then also spoke to, it's like, yeah, when these people get access to services, they can be in the workforce, they're taxpayers, it saves all these costs down the line, and neither of those things are the reason that that individual works for the region, has devoted his career to this, but it helps someone else understand that there was some data, there was these aligning with their policy agenda, and then kind of a personal connection. And it sounds like it has to be a multifaceted way of communicating. And the part where it's just the right thing to do is the thing that helps you see those connections in everything. You can kind of look in every direction and see how the work can be reflected. So I just think that's that was very helpful advice, and especially kind of hearing it from both of your perspectives. So thank you for that.
Well, if we don't have any more questions, I'd like to thank both Dr. Montiel and Dr. Angulo for spending the time with us tonight to talk about these very important subjects and give us more context about how we can be advocates for the communities that we serve.
Thank you all. Thank you so much for having us.
Thank you.
And we're available. The organizers have our email address, and really anytime reach out. As you see, I'll respond. And maybe not the first try, because Felipe had reached out. We started a conversation, then it took another try, but we got some really cool things done. So always welcome the opportunity to work with all of you.
And since she's always in her car, she'll just drive